Thank you so much, and thank you again for the opportunity to talk with everyone today and to help continue to expand on this program. We're all part of this incredible community, a community that transcends countries and borders, and it is really centered on the privilege of taking care of sick people, our patients. It's a demanding specialty that we're all involved in. It takes a lot from all of us, and so I think forming a community again that emphasizes again the rigors and challenges of caring for the critically ill and building that together is something that's incredibly important to sustain us as practitioners. And along those lines, just kind of tying those sentiments into ECMO and the focus of today's talk. My interest in that technology was really around trying to understand and develop new means of supporting patients with profound circulatory and pulmonary failure. And I would argue that ECMO in general, its clinical use, is in its infancy everywhere. And so the wonders of that is that no place is too far ahead and no place is too far behind, because there's so much to learn in this area and so much to understand and to improve upon. And it's just now making its way into critical care environments. And so how to use this technology is an area of immense interest for me personally, and then I think it's growing in general. So I'm going to try to present some slides here. I invariably, when I do this on Zoom, make a mistake. So I share the wrong screen, I share something. And so I'm going to do my best here. And then please give me feedback if I do this incorrectly. Also, if I talk too fast, tell me. If I mumble or I'm too quiet, please tell me. This is intended to be collegial and interactive. And so please don't hesitate to interrupt me at any point in time. Okay, our slide presenting? Yes? Okay. Like I said, please interrupt me. This is intended to be
yes, it is.
Okay, perfect. It's intended to be informative. So just in general around these concepts of ECMO and what we're trying to accomplish today. This is really an introductory talk, just a tasting menu, if you will, of what ECMO is. I want to get everyone a sense of where it comes from, the technology, what the components of the machine are, and then touch a little bit upon the clinical role of this machine, this device, to give you a sense of its current application, which is very much in evolution now. That's what I hope you walk away with, is some deeper sense of this. And I would be delighted to come back at a future time and really dive into some more clinical cases to describe how I personally advocate its use in different cases of respiratory failure and circulatory failure, some of the challenges in those case scenarios. And so could really build a second talk around some of those more clinical applications. But today is really intended to be an introduction. The device itself and the first part of the story is really built around cardiopulmonary bypass. ECMO itself, the machine, is an evolution of the cardiopulmonary bypass circuit. It was then adapted from that circuit to providing temporary support for circulatory respiratory failure in the ICU. And in the United States, its growth as a respiratory support modality, especially in the adult population, really started to take off after the time of the 2009 H1N1 influenza pandemic here. And so for better or worse, oftentimes military conflict, war, and then infectious pandemics really lead to a lot of innovation in medicine. And so we saw this increase in the use of COVID, the growth of the number of ECMO centers in the United States after 2009. And then fast forward to the time of the COVID pandemic, and then I'm being interviewed by news stations asking me what ECMO is and what its uses are. And so just in that short 15, 16 years between then, there was an enormous growth. And now, of course, there's a global interest in this technology. Taking a step back, way back, just to provide a historical purpose or perspective, a lot of the technology that underlies ECMO, again, came from the interest in cardiac surgery and early efforts at cardiac surgery. And just in the history of medicine, were profoundly unsuccessful and difficult. The first recorded case of successful cardiac surgical intervention was way back in the 1890s in Germany. A young man had a stab wound from a knife into his right ventricle. right ventricle, as everyone in this call knows, is a lower pressure circulatory support system than the left side. And so that's probably why this particular patient survived having his chest opened and then had his RV successfully sutured closed. And he somehow survived, didn't get sepsis, recovered. The surgeon gave him what apparently was very good postoperative advice, telling him that not to work too hard after getting stabbed in the chest here. But that was the first recorded case. Ironically, then step forward about 6 years, the first case in the United States was in 1902, where a doctor, Dr. Luther Hill, was actually giving a talk at a local Veterans of Foreign Affairs or Foreign Wars facility in Alabama, I think. Actually giving a talk on Ludwig Rhine's successful surgery when somebody locally was stabbed in the chest, stabbed by into his LV, and so he was actually taken, operated, what sounds like in a shack next to this house where he was staying under a kerosene lamp, so not exactly sterile conditions, and somehow managed to suture close his LV, and the patient survived for almost 40 years until dying in the age of 50 when he was stabbed to death. And so either that means, endemic violence in the United States has always been present 100 years ago, present now, or else to describe that the kind of characters this particular patient happened to be surrounded by, but somehow managed to survive being stabbed. But this again kind of illustrates the challenges around cardiac surgery. The reason so few patients actually survive these kind of cardiac interventions was because of the difficulties of actually operating on the heart. Around this time, also rheumatic heart disease, is a global challenge and a lot of valve issues. And so patients would develop calcified stenotic valves, and surgeons would attempt to operate on them, doing finger valvulotomies. And so cutting off first string suture basically into the atrium and sticking their fingers through the mitral valve to knock off the calcium. Patients did not do well, probably not surprising that almost everyone died after undergoing this procedure. And so clearly just opening up the chest and sticking your fingers in the heart was not a successful, typically operative experience. And so, skipping forward some of these other cases, including some Johns Hopkins history here, the Thomas Blaylock shunt, just an incredible bit of operative innovation, really led by Vivian Thomas here at Johns Hopkins, and just a wonderful bit of early history in terms of cardiac intervention, but incredibly challenging surgery done without the benefits of cardiopulmonary bypass. So in the background to these really unsuccessful efforts at cardiac surgery, or rarely successful efforts at cardiac surgery, there was this realization that to operate on the heart, you needed to somehow take over the work of the heart while allowing you to intervene upon the heart in a non-functional state. And that meant you had to do two things. One is you had to, if you're going to bypass around the heart, you had to figure out how to oxygenate the blood, how to do the work of the lungs. And so at the same time, there was a variety of different efforts to artificially oxygenate blood. Again, German groups back in the 1800s were coming up with film oxygenators. And these were things where they would take blood out of the body and literally spin it against some sort of canister. You see this down here in the bottom portion of the slides. And so forming a thin wall of blood basically adhering to the surface of this as it dripped down. And so that would create a blood-air interface to allow for gas exchange. Other individuals were interested in developing methods of pumping blood through perfused organs. This led to the development of a lot of engineering collaborations, which again, part of my interest in this area. We had automotive engineers from General Motors in the Detroit area working with Wayne State University in Detroit, physicians trying to develop new ways to pump blood. And so with the oxygenation problem, and the other problem in cardiac surgery was, if you're going to operate on the heart and have the heart not working, how do you pump blood to the rest of the body? And so they developed various kinds of pumps. This pump looks suspiciously like an automotive engine. You can only imagine how fast it could go, how much blood it could pump. But this is what you get when you work with automotive engineers who creating an automotive pump to replace the heart. This all eventually started culminating in larger and larger, more extensive circuits. Just to give you a sense of the technology at the time, William Mustard was recruited to lead the cardiac surgery program at the University of Toronto in the 1940s. There was no cardiac surgery program. He was actually trained in orthopedic surgery. So you can imagine the jump he had to make going from bone surgery to transitioning to heart and lung. And so he started operating on congenital patients. And so as you can imagine, there was increasing interest on neonatal cardiac malformations because infants would be born with profound cardiac impairments and would die shortly after birth. And so just a traumatic patient experience for mother and infant, and this entirely a mortal condition. And there was just that realization drove a lot of interest and innovation. And so there was this effort to develop circuits primarily for operating on this patient cohort. Dr. Mustard developed this heart-lung bypass machine, and he used automated pumps, but for the oxygenation portion, he actually used rhesus monkey lungs. So his oxygenator to solve his gas exchange problem was to pump blood through rhesus monkey lungs that he had explanted from monkeys and basically suspended in a circuit here. So had a ventilator pumping air into the lungs, and then through the pulmonary vasculature would pump blood from the patient. Not surprisingly, blood exposed to that external environment developed profound allergic or immunological responses. And so essentially all patients who underwent this, except for 3, died. So but he kept at it in 21 operations with only 3 survivors through this time. So again, just shows you the state of innovation in the 40s and 50s, as well as the state of desperation. I'll skip over this in the interest of time and jump over to John Gibbon, who is credited with developing the first successful heart and lung bypass machine. He operated on an 18-year-old woman who had a rheumatic fever and developed an atrial septal defect with a profound left to right shunt. And over a period of a decade, developed a cardiac bypass system that used a roller pump and then a film oxygenator, similar to what I showed you before. And this patient survived the atrial septal defect closure and eventually was discharged home. Not too bad after 13 days after the first open heart surgery. So pretty impressive, and then lived a robust life after that. And this machine down here is an example of that first machine. So this is essentially what the first heart and lung bypass machine looked like. And this is what its current innovation or implementation of a heart lung bypass machine. So this is an example of this is a Drager system that is actively used in cardiopulmonary bypass. So this is what the modern implementation of all this is. So forgive me for taking so much time on a bit of cardiac surgery background. I find this technological innovation just interesting and a driver of the current use of ECMO, which is really dependent on those early innovations. And we'll dive into some more of the technology here in just a second. The heart-lung machine, as mentioned, really does 2 key pieces. One is to maintain perfusion. And then if you're sending blood from the venous side to the arterial side, you then have to maintain gas exchange. And so somehow perform gas exchange on blood that you pulled outside of the body. So those are the 2 key technological pieces. When you look at these broader components of a cardiopulmonary bypass circuit or ECMO circuit, there's really only 2 main pieces, a pump and an oxygenator. And that's how we simplify it from that larger cardiopulmonary bypass circuit. It's something to pump the blood, and then it's something to perform that gas exchange. And all of this now can be packaged into a much smaller device than what you see with cardiopulmonary bypass circuits. And so this is the McKay CardioHelp, which is one of the smaller implementations of bypass, where it has an integrated pump and oxygenator. And then it's a very portable design, so very useful in transport, also for mobility. And there's a fair bit of innovation around this, other companies coming out with their devices now. So this is what a more modern, technologically elegant version of this technology looks like. So early circuits and still in neonatal circuits rely on roller pumps. And roller pumps are kind of the workhorse pump laboratories like mine. You'll see these in renal replacement devices, so dialysis circuits, things like that. We'll use roller pumps, and how they work is basically that central axle just rotates around, compresses tubing, and advances flow of the liquid across it. Now, the good thing about this, very easy to use. You just basically prime the tubing, and so you have tubing and you fill it with fluid, so you get rid of all the air in it. That's pretty easy to do. And then it's also afterload independent. And so what that means is, as long as you're in the operating conditions of the pump, whatever rotations you push forward for that pump, it's going to deliver that flow. So you know exactly how much flow you're getting per rotation. The downsides of this is it's traumatic to the blood. You're literally squishing the blood between the rotor heads of the device. And so that causes mechanical trauma. So you're shearing blood, you're causing hemolysis, you're activating white blood cells, you're activating platelets. And so it's very injurious to the blood. And that's something to think about with extracorporeal circuits. You also wear the tubing, the same portion of tubing. If you're doing this day after day, if a patient's on a circuit for 2 days, 7 days, 2 months, that tubing gets worn out. You can actually have tubing rupture. And so you can imagine if you're flowing 5 liters a minute through these devices, and suddenly the tubing ruptures in the middle of the night, the patient's not going to do well. You're shooting blood all across the ceiling of the room. It's horrific. And so that's a big downside of these devices. And then there's another problem, which is something called spallation, which is basically where you get small little bits of the plastic of the tubing embolizing off into the circuit and getting sent forward. And so that's a major challenge with all of this. And so those challenges led to the development of centrifugal pumps. Centrifugal pumps, the good thing about these pumps is that you now have less activation, less trauma to the blood. There's no spallation of the tubing. So blood basically gets pulled in and then injected out. So through this little side port here. The challenge with it is that it's afterload dependent. So how much flow you get is going to depend on the resistance that the pump sees. And so if you set a certain RPMs, you're not going to get an exact flow to that. The flow will vary depending on the resistance that the device sees. It's a little more difficult to prime. So if you get air in it, it's a little more difficult to get those air bubbles out. And then also, I speak as an engineer, it's harder to integrate feedback into it because it's spinning so fast that you can get things like suction events and other challenges that make it hard to build a smart pump that will automatically titrate. And so based on how I have my Zoom set up, I can't see the chat. We both the chat. I think. Okay, I wanted to make sure are there any questions at all? No? Okay, good. I'm sorry, I thought I saw some questions pop up. But these are all again different components of the circuit itself. And so the oxygenator development, the early portions of the oxygenator were very challenging because, as I mentioned, the first oxygenators that were built were exposing blood directly to the air. And so they had bubble oxygenators. We would literally have air bubbles bubble through a reservoir of blood. I mean, this sounds like some kind of witch's brew, right? Of like, a big vat of blood and like bubbling air through it. The other thing is, creating a uniform interface for blood to be exposed to air. That led to that spinning contraption with thin film oxygenators. So you have this really like this single cell layer of blood dripping down across the wall with air going up against the other side. The challenge with that is, what does air do when it hits, or what does blood do when it hits air? It clots. And so the amount of heparin you need, or anticoagulants, to operate these oxygenators is enormous. It creates bleeding challenges. It's incredibly activating to the blood. Again, that common theme with these devices is that you're activating the blood when you take it out of the body, which creates challenges under the patient. So a major technology innovation here was the development of the hollow fiber membrane oxygenator. And this is Ted Colombo at the NIH. This is a young Warren Zapol next to him. So Ted Colombo developed using dialyzer-like technology, the silicone membrane-based oxygenator. So he took mats of hollow fiber tubes and created the oxygenator from them. And that was just an incredible innovation. And so essentially gas would go through the middle of these tubes and blood would be passed around the outside of the tubes. And so blood would pass around these devices, and then you've got that gas going through the middle, separated by that thin film. And so now you've separated the blood from the air. So the blood is interacting with the silicone, which is much less activating than actually being contacted with air directly. And then air would perfuse across these membranes, which are semi-permeable. And so that would allow for gas exchange. And so this was a major innovation. And this became the default oxygenator of cardiopulmonary bypass circuits for decades. And then became the primary oxygenator-based one for ECMO circuits. Until the more recent development a couple decades ago of polymethylpentene. And this was a new material. And there's other materials that are similar, polyethylene based, that allow for a little more stability of the oxygenators and a little less degradation of the material. And so one of the challenges with having blood, this kind of liquid medium surrounding these air-filled tubes, is you eventually get some perfusion or diffusion, I should say, of liquid plasma, other things, into the lumens of the oxygenator themselves, which would degrade the performance over time. And so the silicone was slightly permeable, and so they were graded for use for about 6 hours or so, although you could use them for longer. Whereas the polymethylpentene ones were initially rated for about 14 days of continuous use. And we've developed a variety of methods to try to prolong their use. I've used a single oxygenator on the same patient for up to 2 months. Very lucky. Sometimes it only lasts a couple of days. And we've developed a variety of techniques to try to make these oxygenators last longer. Like burping the oxygenators, we jet through a higher sweet gas through the middle to get rid of and expel any sort of condensation that builds up. But that's the core idea, is that now you've got this gas exchange device and you've got this pump. And those two components are really the core elements of the modern oxygenator, or excuse me, modern ECMO circuit, a centrifugal pump and some kind of oxygenator device. You can build in all sorts of additional technology, monitoring technology, other sorts of feedback, but at the foundation of it, it's a pump and an oxygenator. Now, if you've waded into the medical literature and tried to learn about ECMO, it is a dangerous place. And I should say it's at the very least, it's a confusing place. And so there is enormous variability in terminology. There's enormous variability in people's understanding of different components. I find the literature oftentimes to be profoundly confusing. And so if you're just getting a handle on what ECMO is from what's out there, you can be overwhelmed quickly. It's a wide variety of different terms and acronyms that are not very enlightening. And one of the challenges of this is that we use this term ECMO, which doesn't say much, right? Extracorporeal membrane oxygenation. That basically means outside the body artificial lung. It's like, okay, what does that actually mean? It depends on how you connect it to the body. And you'll see, in general, two main forms of ECMO described in literature: VV ECMO, veno-venous, and VA, veno-arterial. With veno-venous being where the blood is coming from a vein, returning to a vein, versus VA, coming from an artery or coming from a vein and returning to an artery. So, and then people will make up other acronyms. Veno-arterial venous, when you have the return split between arterial and venous. Venous pulmonary artery, VPA, So there's, again, different variations of all of this, which is very confusing. But in general, these are the two predominant forms. And forgive this horrible joke here, but again, it becomes important in terms of plumbing. Yes, it's all water, but the function of the device is entirely dependent on the plumbing. What you connect to where becomes very different devices and have very different uses depending on where your tubes are connected, as it were. And so VV, we think of as purely providing gas exchange independent of circulatory failure. And so you're pulling blood out of the veins, systemic veins, returning it to the systemic veins. And so you're performing gas exchange independent of the injured lung when you connect the tubing to the circuit that way. If you're pulling blood out of the vein and then returning it to the systemic arterial system, you're now providing circulatory support. So that's VA. You're now perfusing the arterial system independent of the failing part. And so that's a form of circulatory support. And so that's the easy way to think about these two techniques. Now, VV ECMO in general, some physiology to think through. It depends on what the type of respiratory failure that you're dealing with that you want to support. And so patients with profound hypoxic failure, how is blood or how is oxygen carried in the body? It's carried predominantly by blood, very little dissolved oxygen. And so that means you need a large fraction of the venous return to be captured and pulled into the extracorporeal circuit for ECMO to provide respiratory support in the setting of profound hypoxic failure. In hypercapnic failure, due to how CO2 is transported in the body, you need less blood flow because CO2 is also present in the form of bicarbonate. And so you can perform full support of hypercapnic failure with a lower level of extracorporeal blood flow to the circuit. On the VA ECMO side, you'll see a couple of different cannulation strategies. In general, to further describe the nomenclature, you'll see what we refer to as central VA ECMO. And what we mean by that is that's where the return cannula or arterial cannula goes. We put it in the aorta. And so you can imagine if you're doing open heart surgery, the patient's heart is not recovering very well at the end of surgery. It was a difficult surgery. Patients that come out maybe initiated on VA ECMO in that setting because the chest is open. Direct cannulation into the aorta allows for what's called VA ECMO support, and that cannulation site in the aorta, we refer to that as centrally cannulated. Versus what's becoming increasingly popular, especially as ECMO is used more and more in medical patients who not undergoing sternotomy, things like that. We'll do peripheral cannulation primarily through the femoral artery, and so that'll be referred to as peripheral VA. There's a variety of different cannulation approaches for VV ECMO. You'll see these double lumen cannulas, which are basically like giant dialysis catheters. There's one made by McKay called the Avalon, another one made and marketed by Medtronic called the Crescent. They are enormous garden hoses basically that you put in through the IJ, and they go all the way down to the IVC. So they'll pull blood out of the IVC and SVC simultaneously and return it through another lumen directed towards the tricuspid valve. Versus having one giant tube going in the femoral vein up to the level of the IVC RNA, pulling blood out through the circuit and then returning it through a cannula in the IJ. Or femoral, and that's a lower flow support modality. But again, different combinations and ways to support patients and different placing of the plumbing, as it were. So ECMO device management in general is quite limited. This is one of the challenges with supporting patients on various kinds of ECMO support. It is incredibly under-engineered technology. We have an oxygenator, and the only thing that you really control through it is the sweep gas. And that's the gas that runs through the device, which is diffusing across to form gas exchange with the blood. And so you can choose the composition of the gas. And for most adult patients in respiratory failure, we choose 100% oxygen. And we may blend it with room air to vary the oxygen content, but it's typically about 100% oxygen. And then it's how fast we can run the sweep gas through the oxygenator, sweep gas flow rate. the faster the gas moves through the oxygenator, the more CO2 it entrains and removes, because there's less time for the CO2 to reach equilibrium from the blood side to inside the fibers. So the faster the sweet gas is moving through, the more CO2 you remove. You can think of it as the oxygenator breathing faster. So the faster you're running the sweet gas, the oxygenator is breathing faster, it's getting rid of more CO2. The other thing you control the ECMO circuit is the pump speed. If you have a centrifugals pump, you're controlling the revolutions per minute. And so all you're controlling with the pump speed is how fast it spins. In general, spinning faster, more blood flow. And so you can push your blood flow by increasing the rates. Eventually, you'll reach a limit. Either your RPMs will be so fast that you're causing a lot of physical trauma to the blood and causing a lot of hemolysis, or you're getting such negative pressure at your cannula that you're getting suction events. You're pulling out more blood than the body has coming back from venous return. And that'll limit your blood flow through the device. So again, there's not a lot in these devices. In my own lab, we have a bunch of old ECMO controllers. To give you a sense, CardioHelp sells those new devices, or McKay sells new CardioHelps for more than $100,000 a piece. I think they're like, my goodness, with inflation, everything else, 120, 130. We'll have to see how much they sell it for now, but quite a bit of money. Spectrum Health, these other companies, those devices will be between $100,000 and $200,000. My goodness, that's a lot of money. No laboratory has that kind of money. So we go on eBay, the wonderful medical device resellers in the world, and we get used ECMO devices for our lab. And so we have this utterly ancient Medtronic device, which is perfectly good, which we got for about $500 on eBay. And so that gives you an example of the price range. It's always buy used. That's why you can save a few dollars if you find something like that. And then the last thing you control with these patients is cannulas, like where you stick the tubes, or where you stick the plumb, basically. Okay, so a little bit of word just on the literature and the state of evidence for ECMO. One of the reasons I became an ECMO doctor is there is no evidence. I love this field because I don't have to memorize a ton of studies and a ton of papers to justify its use, because there's practically no trials showing any benefit. And the current state of evolution of this is our practice patterns and how we titrate support and use the device. My goodness, it's driven by expert opinion, emphasis on opinion. And so we have very limited, really well validated data to support our practice patterns, how we titrate support, what patients we use it in. And so as a result, a lot of this is driven by experience. The downside of that is that given the state of technology and where we are with clinical use, the outcomes that we see are profoundly variable based on clinician expertise. And so if you have a particular ICU doctor on 1 week, you may have one management strategy that leads to better outcomes. And the next week, you'll have a different physician and have very different outcomes. And that's really one of the big challenges with this device, is it's a brand new, in many ways, emerging device, emerging technology, and it's nowhere near standardized as, say, the ventilator. Whereas ventilator practices, we have a big body of literature which describes their use, yes, for critically ill patients with profound failure, a lot of variability in how to manage and titrate ventilatory support, which may change outcomes. But I would argue that for the 80% of ventilator use, we really have harmonious practice, which has limited some of the egregious use of that technology. We're really at the infancy of this with ECMO, so all of this to be defined. This is some of the history of this, and so some of the first cases in the literature is really populated by all these cases of heroic saves that are then hard to replicate in mass. The first reported case of ECMO was way back in the 70s. This was a young man who basically, I would argue, survived in spite of medical care as opposed to because of it. He was, I think, hit by a car while walking, developed profound traumatic lung injury. He eventually survived a hospital discharge. He was cannulated on VA ECMO to provide oxygenation. They put a cannula into his artery all the way up to his proximal aortic arch. And then they ventilated him something like some incredibly high tidal volume. And so he survived probably from the benefit of being young as opposed to the care that he was provided. But we'll go down in history as being one of the first cases back when the journal still published case reports. And then Bob Bartlett, really the father of modern ECMO, cannulated a 2-year-old with cardiac failure following surgery, and then used ECMO subsequently to treat respiratory failure in a neonate who was dying from a meconium aspiration pneumonia, and had successful outcomes. And then really became a pioneer in the use of ECMO to support the University of Michigan for decades. Coming out of that work was a series of early clinical trials that were just profoundly unsuccessful. And you see, way back in the 70s, some of the efforts that people had in trying to use ECMO. They compared conventional mechanical ventilation, whatever that meant in 1979. This is 23 years before the first ARSET trial. And then they used partial veno-arterial bypass. So again, sticking an ECMO cannula all the way up to the aortic arch. 4 patients in each group survived. So my goodness, less than 10% of patients survived in each group. I mean, this shows you what the level of critical care was then. That conventional mechanical ventilation led to 9% survival rates for acute respiratory failure then. So on the basis of trials like this, people really did not pursue ECMO very aggressively at that time. And as a result, it was left as kind of an orphan technology, I would say, in the 70s. Until Pearl Bailey, down here in the 1980s, when she was a young intensivist at Boston Children's Hospital, started to use it in neonatal patients. And so, she was caring for these neonates born with cyanotic heart disease, who essentially would die after birth. Said, wow, I read about Bob Bartlett, and Bob Bartlett down here, picture 1974. I know he's experimenting with technology. Why don't we try this? Why don't we basically use a modification of our cardiopulmonary bypass circuit right after delivery in one of these cyanotic cases, see if we can bridge them to surgery successfully. And she received so much criticism from the medical establishment for trying this. She said, what you're doing is without evidence, you're subjecting people to basically clinical experimentation. But she had incredible results. She had 80+% survival versus the background was 10% survival. And there was all sorts of debate in the field about, well, how do you even conduct a trial now? Should you expose people to standard of care, which is to do nothing, or try to rush them to surgery, where you have 10% survival, and she's showing 80% survival. So on the background of that, ECMO became widespread and used as a neonatal technology and in the pediatric ICUs. And that correlated with my own graduation and emergence into critical care in the early mid-2000s, where I started caring for patients as a critical care fellow in the H1N1 pandemic. And it was around that time when we started looking at our cardiac surgery colleagues across the hall and said, hey, you've got that machine over there, that bypass machine. I've got a 30-year-old who was dying from pneumonia. And that was really what motivated our use of ECMO at that time was pneumonia is oftentimes, referred to colloquially as the old man's friend, basically being a way of passing, of dying in old age. But then influenza, the H1N1 pandemic was unique in that it affected a number of young people. And so given critical illness in younger populations, it pushed us to do more experimental therapies in an effort to decrease mortality. And that really helps spur innovation in ECMO, as mentioned. And so I was able to experience that as a fellow, and then seeing that really motivated the next phase of really my professional career, which has been built around developing these technologies. I'm gonna skip through a fair bit of this just in the interest of time, because my goodness, I could talk for another hour, as you can probably tell. And I just want to talk a little physiology first. So the first thing is on practical conditions. And so we'll talk about VV ECMO for just a second. So VV ECMO, in supporting a patient with respiratory failure, the first thing to realize is it's not a treatment. We're not treating anything. All we're doing with it is performing gas exchange, independent of the lung. in an effort to maintain homeostasis. And so you have a patient who, let's say, is dying from a horrible pneumonia. Let's say they've been intubated. The progression of that pneumonia, that lung injury, is going to be driven not only by the underlying infection or the primary injury to the patient's lung, but then also, as you get worse and worse lung disease, what are we doing? We're trying to maintain adequate oxygen delivery, adequate CO2 delivery, whatever that means, to keep the overall patient alive. We're relying on that dying injured organ. And so what do we do? We're beating it with the ventilator. We're forcing air in. We're trying to maintain gas exchange. And that's putting an increasing burden on those injured lungs to maintain homeostasis and equilibrium. So what we can do is take some of that burden off the injured lung and put it onto the extracorporeal circuit. Now, when we do that, we allow the opportunity to change how we manage the ventilator. And so perhaps we can decrease the burden of injury from the ventilator to allow the lungs to recover. Will they recover? We don't know. What's the optimal setting on the ventilator to allow for recovery? We don't know. All of this is expert opinion, which basically means loudest voice in the room. And as you can tell, I like to be the loudest voice in some rooms. And so in my local institution, I will yell for how I like to do things. But I have to be at least somewhat humble and realize I don't have a lot of evidence for what I do. It's based on experience. It's based on exposure to patients, trying to replicate it in the lab. But a lot of what we're doing at this point in time, my goodness, it needs to be discovered and understood. So there's no common practice on it. But that's the first thing to really think through. It's VV ECMO itself. It's not a therapy, it's a support modality. But the other half of that, how do we promote recovery from acute lung injury? We don't really know. And I hinted at this earlier, which is the amount of oxygen you deliver with VV ECMO is dependent on how much of the venous return you deliver. Because oxygen, 97% of your O2 content in the blood is carried by hemoglobin. And so your hemoglobin content and how much of your hemoglobin and your venous return you're pulling out to the circuit is going to determine how much oxygen you deliver. Now, on the flip side of that is if you have a patient who's primarily hypercapnic failure, ECMO is great at supporting patients with hypercapnic failure. Why? Because of carbonic anhydrase. And so this enzyme rapidly converts bicarbonate, which holds about 90% of your circulating CO2, between gaseous CO2 and bicarbonate. Because of that, you have this huge store of readily accessible CO2 passing through the ECMO circuit that can be converted to CO2 and then exhaled by the circuit. And that allows you to easily support hypercapnic respiratory failures. So think of patients with obstructive lung disease or asthma, or maybe a patient with poor lung compliance with acute respiratory distress disease, and you're unable to adequately ventilate them, but you can maintain oxygenation easily, like some variants of ARDS. The VV ECMO is very adept at supporting that patient population. Whether they recover or not, all depends on that primary disease, as well as can you reduce the burden from acute lung injury. So that's a big aside about VV ECMO, and we can go into much more detail about that. And then the other big use, for those of us at transplant programs, is using it as a lung replacement technology to support patients with end-stage disease while we bridge them to lung transplantation. I'm going to skip ahead to just talk about mechanical circulatory support for a moment. And this is for patients in circulatory failure. And so this is really, to use an American expression, the Wild West. We have this frontier of expanding range of devices and limited understanding of what's the optimal device, optimal titration, how do you use them, or how to use multiple devices simultaneously. And so VA ECMO is really undiscovered country, determining how to optimally use it, how the device interacts with the heart, how it alters systemic perfusion, how it can potentially injure the heart. All of these things are under active investigation that are variably supported by our research institutions. And the final thing I'll mention here, I've got a whole lot more slides, but in the interest of time, I just want to stop talking so we can have a little bit of discussion. I talk way too much. Is that ECMO in a lot of ways I think it's analogous to kind of the early days of renal replacement therapy. And so when we developed the dialyzer and dialysis, we didn't know how to use it. we had very limited access to it. Only a few patients could get it. It wasn't available at home. You had to be in the hospital to get it. So if you didn't recover your kidneys in a timely period, that was it. That's very much the way ECMO is today, because there's a very limited window of supporting patients. There's not a home-based technology for patients with lung disease. And so, recovering to some level of baseline function is vital, and then how to optimize patients to recover, we don't know. And I think of one of the big challenges of this from a clinical standpoint for all of you in your careers as you get exposed to these technologies is medicines are incredibly complex, developing those molecules, things, but how you deliver them, a little less complex, right? We can give someone a pill, we can give someone an injection. There's technical aspects to that, but again, the complexity was probably in developing the medication. Whereas ECMO, it's a machine. And so how to fly that machine, if you will, is much more complex. And your success at getting from point A to point B in an airplane is very dependent on your pilot. And that's very much true about ECMO, as if you want someone who's experienced and has understanding of the physiology to guide support. Whereas in today, that's highly lacking because there's not a lot of uniformity to this. And then I would argue that present day ECMO is not like some incredible device where you have all these feedback and all these gauges and all these automatic controls. It's really a much more limited set of controls and things to operate the device. We have limited feedback. And so a lot of it is putting your finger up in the air saying, I'm going to go up and close or go down, sit there with the echo probe. Modern day management of this, again, is incredibly user dependent. And so we're really, I would say, at the infancy of this technology, which is something that for all of you, hopefully is exciting, because I'm hopeful that you'll be a part of helping to establish this technology in home countries and programs, and then helping it grow in the decades to come. Because I believe, especially on the respiratory side, this will be part of the future of critical care. It's something that you can help establish in your institution. I talked way too much, and I talked way too fast, so thank you. Let me stop here and see if we can have some questions, and I'll stop my slides here so we can pull pictures up and see each other. I can figure out how to see.
Thank you very much, Stephen. And so my very first comment